Well, let me just say thanks for inviting me here. I really appreciate it. I wasn't able to make your meeting last year, and so I'm really glad that it worked out this year.
Thank you. Well, good morning again. Here we are with, I sort of joked, this is a fireside chat by grass. Good morning again. And one of the areas that we wanted to kick off as we're looking at this as this day is really looking ahead at the future. And again, it's no surprise we're focusing on innovation today. And to have Liz given the focus on innovation it's no surprise that the leadership of CMS, and we heard from Chiquita in pre-recorded remarks yesterday, that the center took a full look at their strategic plan, and at the Innovation Center that you have refreshed your strategic plan, and it focused a lot on person-centered care. And so Liz, if you could just speak to, as you're looking at that, and just share with the audience how you have prioritized that and what you're doing in updating the work that you're doing on person-centered care, and reflect on your vision. I know a lot of times when you're at the agency and you're doing the day-to-day work, sometimes you can lose sight of, not you personally, but having sat over at the department, you can lose sight of that big picture. So to be able to just do that step back and share what you see as that vision in that strategic plan of person-centered care and update us on what you're doing.
Sure. Well, thank you again for having me. And so I've now been at CMMI, the Innovation Center, for since March 2021. And when I first got there, we did a lot of interviews and looked back at the evaluations from the models that we had run, 50-some models, talked to experts, talked to model participants, talked to stakeholders, maybe some of you in this room, to really learn how the models had been working, what's not. That effort culminated in the release of a strategic plan, or a refresh, that was very consistent and aligned with the vision that Chiquita, our administrator, Chiquita Brooks-LaSure, had laid out for us. So our strategic objectives align very closely with Chiquita's vision for the agency, or the administrators. It is hard because you're friends with people and then you also want to make sure that you're respectful. So I will also say that it's been a true pleasure to work with such great leaders at CMS and HHS who are longtime colleagues, just like with you. We've known each other for decades. But our strategic objectives, first of all, we can't, what we did in the first 10 years of CMMI was throw a lot of spaghetti against the wall to see what sticks. And I think we can't keep doing that. And so we really wanted to center on sort of what we thought was working and give stakeholders more of a direction or a vision where we were heading. And that vision includes accountable care. So we really are placing a lot of bets on accountable care. We want 100% of fee-for-service Medicare beneficiaries in an accountable relationship with a provider who's looking out for their total cost of care and quality, and as well as with the vast majority of Medicaid beneficiaries. We also want to look at some point, and haven't gotten this far, if you're in Medicare Advantage, making sure that you have those relationships with your providers as well. Although it is a capitated environment, we want to make sure that that sort of patient navigation and assistance is happening, because a lot of times, even though it's under a capitated arrangement, may be paying providers based on fee-for-service. The second pillar is health equity. We've really made a commitment to embed health equity into everything that we're doing. Supporting innovation to make sure that we're giving our model participants the data that they need and the tools and the resources to be successful. Affordability, which I think is where it comes in, some of the work that we have done, for example, on prescription drug prices, and the executive order on Friday directs us to still consider models in that area. And then finally, and maybe where it comes into play with Better Medicare Alliance, is partnering to achieve system transformation. We want to make sure that whatever we do is aligned with the direction that others are heading, and can we help corral change and healthcare transformation that we want to see towards value-based care. So working with private payers, working more closely with Medicaid agencies. So that's the direction that we've laid out. Since last year, we've been building the foundational elements that we need to execute on the strategy. We're getting ready to put out a one-year report, sort of here's what we've been doing, and a refreshed and an updated version of our pipeline where we're heading in the future. But I think in terms of the person-centered care, that again is consistent with the administrator's vision, we also discovered that we had spent a lot of time talking to payers, providers, and health systems, but we hadn't been spending enough time talking to patients. So we've really committed to incorporating patient voices into our models wherever we can. Last month we held a webinar where we announced that we were going to incorporate patient-reported outcome measures in our models for every model. So making sure that we're including that patient voice. So we might be improving quality in some ways, but is it really the way that patients interpret quality, and are we really improving their care experience? So I think those are some basic elements.
Thank you. And we're very aligned on that person-centered care, and then also just as you talk about the value-based care, again, I know I mentioned we have our panel later today, so we'll look forward to digging into that as well. As you talk about the models, I know the Innovation Center has 30 ongoing models, and you're continuing to build on that and accepting applications. Regarding those models, if you can just speak to what the center is looking to accomplish in the long term regarding the models and how you see in those learnings the success that you're looking for in those innovations from each of those models going forward.
Sure. Well, if you were to look at sort of what's met the statutory standard, so of the 54 models we've run since our creation in 2010, out of the 54 models, I think only about 4 have been certified as successful, like either lowering costs and improving quality. And I'm afraid that if you just looked at that number, you would think, well, we're not making a difference. But the way that the statute defined success was through this notion of certification, which is the Medicare actuary or CMS actuary says that there's a 95% certainty that we're going to reduce costs on a net basis into the future. That means any investments we make, for example, in primary care or in underserved areas, counts against us in the sort of the calculation of whether we've been successful in lowering costs. It's a really high bar to make, and so the models that have met that standard aren't necessarily the ones you would think are really transforming the health system. So we're really trying to think about transformation differently. Of course, we still have our eye on the ball of reducing costs, but healthcare transformation is more than just reducing costs. Again, if you're going to really center around patients, it's really that patient experience. So how we measure quality, we're sort of rethinking that. And then how we define transformation, I think we're giving a look at, did we reduce health disparities? Is the model something that can be picked up and carried by other providers in the system? So there's other metrics to how we might define success, and so we've got an ongoing effort. Because if you were to look back another 10 years from now and it's only another 4 models, putting on my hat as a former Hill staffer working for the Senate Finance Committee, I would say, well, it doesn't look like they've been that successful. Maybe we should just take that money and go somewhere else. But as I go out around the country and I talk to providers and other payers, and we have made a tremendous difference and really seeded a lot of change in terms of how care is delivered and how the care experience happens for patients. So I think we've made a big difference. We just need to be able to express that and carry that forward. So we're thinking about success differently of those 30 models. And again, trying to really focus our bets on where we think the biggest change and transformation is most possible. I will say, and I think we need to acknowledge, in some ways the pandemic was a real spur for value-based care, and in some ways it was a real detractor. I think the providers in the system that had invested in value-based care were more resilient and better able to withstand sort of the precipitous drop in volume. But on the other hand, coming out of the pandemic, everyone we talk to says, that there's still some real pressures in the system around workforce, for example. And I think we had hoped that the pandemic might spur more investment in value-based care, but I think we need to be realistic about what providers are able to bear at this point.
I just want to remind folks, I know I have the fortunate opportunity to be up here asking questions. We're going to make sure that there's time at the end for the audience to ask Dr. Fowler a few questions. So Jonathan is going to walk around and share cards for you to put questions on, and then we'll share them with Dr. Fowler at the end. And we are going to be prompt at the end to allow Dr. Fowler to exit. She is returning back. I don't know if you're officially going back to the department in these hybrid days. It's unclear where people are continuing their work. She has a meeting back at the agency. So as I said when we had Catherine Coleman here, we always want to make sure we get our officials back to their offices so they know we're prompt and efficient, so you keep coming back. The next question I wanted to ask, and you were talking about one of the models and how you're focusing on health disparities, relates to the RFI that the administrator and the CMS team had put out last August, which again, that also seems so long ago. It was only in August, and we greatly appreciated the RFI being put out because it gave this is on Medicare Advantage and focused on health equity, one of the critical pillars that the CMS has been focusing on, because it gave our community really an opportunity to weigh in on one of the areas that we're aligned on in strengthening Medicare Advantage, and again, focusing on the person-centered care. And we also appreciate that it gave the MA community and many of our allies an opportunity to weigh in, and we had over 100 of our allies respond to that, and many of them are here: the Hispanic Medical Association, the Black Nurses, American Physicians Group, excuse me. And so, Dr. Fowler, I'm just, interested in that response. What are you all looking at getting out of what our allies have, responded? And with those responses, how are you looking at, following up on what you're hearing from the community?
Well, first of all, we're thrilled that over 4,000 comments were submitted in response to the RFI. So as you can imagine, we're still reading them. And a lot of that task falls to my colleagues under Dr. Mina Seshmani's leadership, who runs the Center for Medicare. So a lot of the policy that you'll see coming out of the responses will be driven by her and her team. But I think, speaking for the agency as a whole, we really see Medicare Advantage as an important part of the program. As we start to review some of the comments, we see a lot of positives. Like you said, there's a lot of investment in communities, in improving care, and the lower premiums and supplemental benefits are really important to a lot of people. So we see that as a real boon to the program. I think, we also see the other side too, a lot of the friction that patients experience when they try to get care or feel like there are barriers to care, and we're looking at that too. And as well as, of course, as you know, a lot of comments brought up about, are we paying in the right way, or what adjustments can we make, and what can the administration do? So, but I see, as I sit in on conversations from those comments, I know that you're important partners in this room and have a really important role in that equity agenda. For CMMI's part, as we think about health equity, and I mentioned we are embedding equity in all of our models, and that includes collecting data on race and ethnicity and social determinants. When we looked back at the models that we had led and said, are we making a difference for all communities? It turned out we hadn't been collecting the data, or our evaluations really didn't look at those factors. So we've made a commitment that we're going to do that. We're the Aco Reach Model that starts in January will include a health equity benchmark adjustment. So for organizations that care for underserved populations, whether those be historically disadvantaged populations, rural populations, will get a boost in payments that we hope will help them make those additional investments in communities. And we're also requiring a health equity plan. So tell us what disparities you see among your populations, and what are you going to do to address those? We're carrying those elements into other models. I think we're having conversations with Mina and her colleagues about what might be imported into other parts of Medicare. And but we see a lot of opportunity coming from the RFI and through the tools that we have as the Innovation Center to really make a difference on some of these really important issues.
Thank you. Well, sorry about those 4,000 responses, but I guess, we just want to make sure that you're hearing from the community, so better that than the opposite.
Exactly. I think we'd be disappointed if it was 200. So.
Right. But again, sincerely thank you for that opportunity. I know with VBID's come up a bit in the conversation right now, but sort of, I guess, bringing it to a bit of a higher level on what you see as what the future looks like with the VBID model, and just what excites you about that demonstration.
Well, it's one of our few models that we have in Medicare Advantage, and like I said, we're looking for other opportunities, and I think some of the responses to the RFI may give us some future direction about future opportunities in MA, but the value-based insurance design model is a really important component. I see Mark Fendrick, who's sort of the father of VBID, and somebody that we spent a lot of time talking to back on Capitol Hill, who's helped us think about this, but we've gone from 45 participants in that model in 2017 to 14,000, and so tremendous growth. I think the participants see a lot of opportunity in the ability to target some of those interventions. So when you have social determinants of health, you want to provide, for example, nutritious meals or transportation or housing assistance to really be able to target that to the beneficiaries that need it most. I think those are the features that we've heard from model participants as really innovative and potentially holding lessons for what we might use to inform future MA policy. I feel really bad that you're not feeling well.
Oh, no, I actually feel fine. I always say, like, when you have this sort of voice, you get the sympathy vote, but I totally feel fine. Although I'm sorry I'm coughing, because the last thing I want to do is get the head of CMMI sick. But no, but I totally feel fine. The next is, again, we've talked about health equity and just how we're aligned in that space. And we actually, in September, had, and many of you were a part of it, had a convening on health equity, and we were so fortunate to have your colleague, Dr. McKeever, speak at that. And the goal of our convening there was really to bring together a group to follow up on a convening that BMA had a couple years ago, where we were talking about the need to address disparities, and where as much as MA is serving minority health populations, communities of color, and make a lot of progress, there are obviously barriers, and we need to recognize those and build off. And so the convening focused on, again, the progress and then where there are gaps. And so we did that convening, and we actually just had a call the other week with Dr. Seshmani on the report that we'll have coming out of that. But as we talk with you, Dr. Fowler, if you can sort of, again, share where you think the vision should be in addressing those disparities. And again, you just got admitted to the National Academy of Medicine, which is such a big deal. And I know you have all these different awards, so I hope in your busy life you're able to sort of take pause on that achievement. But as you look at that vision of health equity, what do you see as the role of MA as we're continually trying to serve that population?
Well, you should be really proud that MA is 50% of the Medicare program, and there's a reason that people are enrolling in MA, because they see the value in that coordinated care. They see the value in potential for benefits that aren't covered under fee-for-service, and I think it's become an increasingly important part of the program. Of course, we still have folks that are worried about MA, and we hear from those voices as well, but I think there's no doubt that all the folks in this room are really important partners, and important partners in advancing our priorities, including health equity. So I guess from my perspective, it would be really important to make sure that you're collecting data and able to demonstrate what's happening in the programs, those improvements that are made. Like I said, when we looked back at CMMI's history, we weren't collecting the right data. We didn't have the outcome measures. Our evaluations really delving into whether we were making a difference. And I think you and your members have an ability to do that data collection and do that analysis and make sure that you're sharing it with us so that we can see what those opportunities are and what's working and what might be shared in the fee-for-service program as well, where there might be lessons. So I think we see MA plans as important partners, and I think moving this ball down the field is incredibly important, not just for the administration, but for the whole, I'd say the whole healthcare system. Everywhere I go, I'd say all stakeholders are focused on equity, but we have to be able to demonstrate what's working and what's not. So hopefully we'll be able to see more coming out of that, both from our models and both what MA plans are doing and the difference that they're making.
Well, and this question was not a setup, but this is why when I look at our allies and stakeholders here, when we have our webinars and calls and we're always asking for data, this is exactly why. I know we have maybe 8 minutes or so left, and so I don't want to steal that time for my questions. So Jonathan, if this is a good time to turn to the audience for their questions.
All right, we've got a couple questions here. The first question says, thank you for your leadership. What models are you organizing that focus on wellness and prevention, mitigating chronic disease like diabetes? Thank you.
Well, I think that is the notion of accountable care, is somebody who's looking upstream. So rather than waiting for people to get sick, we're actually trying to have an intervention and help people stay well from the start. I think that's what MA is designed to do. That's what accountable care is designed to do, advanced primary care, and the payment incentives need to align with that. So I think that is sort of the heart of what we're trying to achieve. And as I'm, again, now that we're able to travel and going out and talking to providers, just adding a code for care management or diabetes management in fee-for-service is not going to get you the results you need. You really need that coordination and that team-based approach to care where you've got individualized attention so you know which patients are at risk and you can intervene before they travel down that road of becoming ill. I think that's the ultimate gold standard. That's what a lot of our models are trying to do. We need to make sure that our quality metrics, our payments, all the incentives in the system are aligned in that direction. That's part of what VBID is trying to do, is really aligning those incentives and being able to target to those patients that need it most before they travel down that sickness road. So I'd say that those principles are embedded in everything that we're trying to do.
We also have a question that says, what can be done to encourage beneficiaries to answer health equity questions and questions on social determinants of health? They may not always understand the purpose. Thank you.
Yeah, that's a really good question. And just a provider I was visiting with on Monday was saying, like, patients don't want to answer all of those questions, and how do you get them to answer it so that you get that data you need to be able to do the targeting that we're talking about? I think, we're at the cusp of a lot of those questions being asked. Some of those questions we may be able to get from other sources. We may be able to connect data sets, for example, and know who's enrolled in certain programs that might suggest needs that hadn't been met through the healthcare system. But I think asking those questions will become more common over time, but certainly what I hear is that there's a little bit of a barrier and a reluctance. I think what you also need is a trusted relationship with a provider. If you have a doctor that you've gone to for several years, that's your doctor that you know, you trust, you believe that he or she has your best health in mind, I think it will get easier to have those conversations, but I think we're at the early stages of that.
I think those are the only questions in the queue right now, Mary Beth.
Any other questions? We have a few minutes.
Okay. Hi, Dr. Fowler. Thanks for your time. My name's Amy Flaster. I'm the Chief Medical Officer at a company called Concerto Care, led by Dr. Julian Harris.
Yeah.
And I think there are a number of organizations just like Concerto Care among us, companies that are trying to live the mission of value-based care through both the direct contracting model and working with Medicare Advantage. And so to that extent, I'm curious if you have any nudges or advice for organizations like ours, things that you've seen that you'd like to see more of, or pushes for organizations that are startups in the value-based care space.
Well, it's a really good question, and there certainly are a lot of startups and potential disruptors in the field, and then the more traditional partners who've been in this space for a really long time and delivered success to a lot of patients. I think, you know, one of the challenges, and you know, if I may say, is a lot of misunderstanding, and as a direct contracting entity, you may know this. There's a lot of misunderstanding about what we're trying to achieve and a lot of suspicion that this is moving the healthcare system in the wrong direction. And I think what we all need to collectively do is be able to explain the value of what we're trying to achieve in a more direct way with specific examples. So if you're trying to explain what you're doing, it helps to have patient voices. It helps to have providers. What I hear from providers is this is under these models and under certain arrangements. This is why I went to medical school, to take care of patients, not just to do paperwork and sit in an office by myself. I went to work with a team on behalf of patients and deliver better patient care. We hear from patients that they like the home visits. They like when somebody comes to their home and understands what their healthcare needs are. That's the value of what these programs are bringing, and we need to hear from all of you those examples and to help explain to policymakers and policy influencers what the value of what we're trying to achieve really is, because I think if we don't, that sort of misunderstanding continues to grow, and we've certainly seen it as the number of letters we get from people that really think that I think don't really appreciate how broken our healthcare system can be if you don't have that navigation and that care coordination, and what it can be if you do. I hope that answers the question.
Okay, maybe one more question.
Hi, we heard from Katie Adamson yesterday from the YMCA on the DPP program. So I think one of the challenges in that construct is the reimbursement model with community-based preventative programs. What's your thought in, relative to creative payment mechanisms that would support community-based that are well upstream, not provider-based programs?
Yeah, I think that's a really excellent question. So for those of you who couldn't hear, the Medicare Diabetes Prevention Program is one of the models that the Innovation Center launched that did get certification and was expanded, but I think has seen some challenges in terms of enrollment. I think it's seen challenges. It's difficult as a community-based organization to be certified as a Medicare provider. That process is not smooth, especially if you're not a Medicare, you're not a medical provider and you're trying to do things very differently. So we are taking a look at that program. How can we really make sure that we're making the most of that opportunity and enrolling as many people as we can, particularly reaching communities of color where diabetes is there's a higher rate of diabetes. So I think there's a lot of work to do. I think we're also taking the learnings of how providers work with community-based organizations into other models, as we're encouraging all of our model participants to have these health equity plans and start to work with community-based organizations. I think we're going to learn a lot more about some of what could make that relationship smoother and easier in terms of the funding streams, in terms of the referral patterns and the relationships. So I think we've seen some bumps, but I hope we can learn from those bumps and make improvements, because I think working with community-based providers and organizations like that are really going to be fundamental if we want to address some of those social determinants.
Thanks everyone for being here this morning, and please join me in showing our appreciation for Dr. Fowler.
Thanks. You can call me Liz.